So good afternoon, respected faculty. So today we will be continuing the second part of the seminar on the topic that is temporomandibular joint and orthodontics. So according to Green et al., he said that the management of temporomandibular disorder can be done by three approaches, and the first method he said was the conservative method, and the second method is the surgical method. And he mentioned about the third approach, which we generally follow in orthodontics, that is the occlusal reference therapy, that is mainly through the use of the occlusal splint. The occlusal appliances, this can be used to reduce the symptoms of the temporomandibular disorder. And the theory behind this occlusal appliance is that it can function as the alteration of the occlusal condition, the alteration of the condylar position, and it increases the vertical dimension, and it can act as the cognitive awareness, and it also acts as the placebo effect, and it helps to increase the peripheral input to the central nervous system, and it can also help to cause the regression to the mean. So since we'll be talking about the occlusal splint, so the occlusal splint has been classified on different methods, and the various authors have given the classification differently. So according to Occlusion, they have classified the occlusal splint as the orthopedic repositioning appliance, and this they also call this orthopedic repositioning appliance as the anterior repositioning appliance. So this is the first figure which shows the anterior repositioning appliance, and the in this while fabrication of this anterior repositioning splint, the mandible is positioned anteriorly. And he also classified the occlusal splint as the stabilization appliance, in which there is the flat occlusal plane, and it helps in the muscle relaxation of the muscle activity. So the Dawson has also classified the occlusal splint into three categories. That is the muscle deprogrammer, or the permissive splint, in which there is the flat occlusal plane, and it can be fabricated on either on the maxillary or the mandibular arch. And he also classified into the directive splint, or the permissive splint, in which the mandible is guided into the predetermined position. And he also classified it as the pseudo-permissive splint, and the example of this pseudo-permissive splint is the soft splint. Also, the Savicek has classified the occlusal splint into the following categories. That is, he classified into the myopathic splint, in which when there is contraction of abnormal activity of the muscles, then we can give the myopathic splint, and it has the flat occlusal plane with the anterior guidance. He also classified the occlusal splint into the decompression splint, and this splint is generally used when there is compression between the centric occlusion and centric rotation. Then the decompression splint is given, and he also classified as the compression splint and this compression splint is generally used when there is distraction between the centric occlusion and centric rotation. And he also classified it as the verticalization splint, and this verticalization splint is generally used to increase the vertical dimension of the patient. And also classified it as the anterior repositioning splint when the mandible is positioned anteriorly. So the first four type, that is myopathic, decompression, compression, and the verticalization splint, these types have the reference position, whereas the anterior repositioning splint is used when there is the different reference position. So also, Willis et al. Has classified the occlusal splint into three types. That is the flat plane, the anterior repositioning splint, and he also classified the splint as the canine protected splint. And in case of the canine protected splint, the splint has the added acrylic portion in the region of the canine, and this added portion helps in the prevention of the excessive lateral movement, and thus the excessive prevention of the excessive lateral movement will help in the reduction of the loading of the temporomandibular joint. And it also helps in the reduction of the parafunctional activity, and it also helps for the anterior guidance, and which is responsible for the treatment of the myfunctional dysfunction syndrome. So this is the canine guided occlusion, where the canine portion has the added acrylic portion, and it helps for the prevention of the excessive lateral excursion in the canine region. So the miscellaneous classification of the occlusal appliance includes the stabilization splint, the anterior stabilization splint, the anterior bite plane, posterior bite plane, pivot splint, and the soft splint. And we'll be studying about each types of the appliances. So the stabilization appliance, this is a muscle relaxation appliance, and because it is a muscle relaxation appliance, because it mainly helps to reduce the muscle pain. And the goal of this stabilization splint is that it has to eliminate any orthopedic instability between the occlusal position and the joint position. So the stabilization splint, this can be fabricated either on the maxillary or the mandibular arch. And fabrication either on the maxillary or the mandibular arch depends upon certain characteristics. And so the fabrication of the stabilization appliance in the maxillary arch mainly should be done if there is if the maxillary anterior teeth are has the possibility of flaring of the anterior teeth, and also if there is compromised periodontal support of the maxillary anterior teeth, then we should go for the maxillary stabilization splint. And also when there is severe attrition of the dentition, then also we should go for the maxillary stabilization splint. And when the patient, when the splint is indicated for the daytime wear, then we should go for the mandibular appliance. Mandibular stabilization appliance, because this when the splint is fabricated in the mandible, then there is less display of the occlusal appliance while function, that is while speaking, and thus the patient prefer the mandibular occlusal splint rather than the maxillary occlusal splint. And when there is no any contraindication, then we can either go for the patient's choice of either the maxillary or the mandibular occlusal splint. And when there is when there is more loss of the tooth, then if there is when the either of the arch has more missing teeth, then we should fabricate the occlusal appliance in that arch only, because it will provide the greater occlusal stability. So the hypothesis of this stabilization splint is that it helps to replace the patient's occlusal disharmonies. And the second hypothesis is that it acts as a reminder, that it helps to catch and alter the parafunctional habit of the patient. And the third hypothesis is that it helps to increase the vertical dimension of the patient. And the fourth hypothesis is that it helps to decrease the load on the temporomandibular joint during the oral activities. So the stabilization appliance, this can help to improve the temporomandibular disorder symptoms for the most patients, even if their pain is related to the discondyle mechanical disturbance, or even if there is intermittent rocking at the opening, where there is joint pain, joint sound. So this is the stabilization appliance, and when the condyle is located is positioned anteriorly, then this stabilization appliance has the contact on all the anterior and the posterior teeth. But when the stabilization appliance is located at the centric equation, then the stabilization appliance has the contact only at the posterior tooth. So it is recommended that while the fabrication of the stabilization appliance, the centric equation should be used for the bite registration only when the TMJ has no any detectable sign of the athlesia, when there is no noise of the joint sounds, and also when there is no history of the locking of the joint, then we should only go for the centric equation. Otherwise, we should not go for the centric equation while recording the bite, while taking the bite. And centric equation should not be used if the patient has any discomfort when the patient tries to sit at the centric equation position. So in such condition, it is recommended that we should use the orthopedically stable joint position, that is the unrestrained condyle position, and that tries to approach the symmetric equation. But it is not encroach upon the inflamed tissue, that is the retrograde discal tissue. Now going to the another occlusal splint, that is the anterior repositioning splint. So it is an interocclusal splint, and it helps to encourage the mandible to assume the position more anteriorly than the intercuspal position. And the goal of this anterior repositioning splint is that it helps to alter the position of the mandible permanently, but only it helps to change the position only for the temporary period of time. And so that for this temporary time period, we have to adopt the inflamed retrodiscal tissue. And once there is improvement of this retrodiscal tissue, the anterior repositioning splint can be discontinued, and the condyle can be again can be brought back to the to the original orthopedically stable position. So this is the figure showing the anterior repositioning appliance, and it is generally used when the patient has the displacement with reduction. So this is the anterior repositioning appliance, and it has the flat occlusal plane in the posterior region, and in the anterior region there is the occlusal ramp. So this occlusal ramp will help to prevent the occluding the teeth in the posterior region when it tries to bite in the posterior region. So it will guide this occlusal ramp will guide the mandible into the anterior position. So it is recommended that the patients will should use the anterior repositioning appliance when they are in the sleep, and during the day position we should say the patient that they should use the normal position during the day. And this anterior repositioning splint can be discontinued when the pain subsides, and suggesting that they no longer need an appliance. And if the patient has the pain only in the morning, then in such cases we can advise the patient to wear the appliance only as the stabilization appliance during the night. And if the pain of the patient continues, then we can advise the patient to continue the appliance, and we should follow the appliance in every month. So the European Academy of Craniomandibular Disorders, they recommended that this anterior repositioning appliance should be used only for the maximum of 6 to 8 weeks. Now I'm going to another occlusal splint, that is the anterior bite plane. So it is a hard acrylic appliance, and it is worn mainly in the maxillary teeth, and this provides the contact only in the mandibular anterior teeth. And it is primarily indicated to disengage the posterior teeth, so that it helps to eliminate the influence of the function on the masticatory system. So going to the posterior bite plane, so it is fabricated mainly in the mandibular arch, and it consists of the hard acrylic that is located over the posterior teeth, and in the anterior area it is connected by the metalingual valve. And the function of this posterior bite plane is that it has to achieve the alteration in the vertical dimension, and it has to alter the mandibular position. Now going to the pivoting appliance. So this pivoting occlusal splint, this has the it provides the contact at one point on each quadrant. This single point contact on each quadrant should be positioned as far posterior as possible. And so in pivoting type of occlusal splint, when the patient tries to bite in the anterior region, the single point contact in the posterior region will try to disocclude of the condyle in the fossa. So it will reduce the intra-articular pressure, and thus will help to onboard the articular surfaces of the joint. So the splint and also can be the soft or the resilient appliance, and this is a device which is fabricated of the resilient material, and it is usually adapted to the maxillary teeth. And the function of this soft splint is that it has to achieve the even and simultaneous contact with all the opposing teeth. Now there is another type of splint, that is the permissive splint, and this permissive type of occlusal splint, this has the smooth surface that allows the muscles to move the mandible without interference from the defective tooth contents, and so that the condyle can slide back and forth up to the article eminence, and so that it can help to completely sit into the center equation. And this permissive occlusal splint can be fabricated either on the maxillary or the mandibular arch. So the permissive occlusal splint, this can be fabricated on either the maxillary or the mandibular arch, and it has the flat occlusal plane, so that the mandible can slide back and forth up to the articular eminence, so that the condyle mandible can sit into the center equation. And the directive type of the occlusal splint is fabricated in such a way that the mandibular position is predetermined, and this type of the occlusal splint directs the lower arch into the specific occlusal relationship, and this in turn directs the condyle to the predetermined position. And this type of the directive occlusal splint basically should be reserved for the specific conditions, mainly involving the intracapsular type of the temporomandibular disorders. So this type of the directive type of the occlusal splint is fabricated in such a way that the mandible is positioned anteriorly, and it helps to decrease the loading of the temporomandibular joint. So there is another type of the splint, that is the anterior deprogramming splint, and it is also sometimes called as the NTI-TSS, that is nociceptive trigeminal inhibition tension suppression system splint. And it is the simple type of the permissive splint, and if there is no intercapsular disorder in the temporomandibular disorder, this anterior deprogramming splint will improve the temporomandibular disorder within minutes or the hours. So this anterior deprogramming splint is mainly fabricated on the anterior, either in the maxillary center incisors, or it can be fabricated on the four incisors of the maxilla, and it has the contact only on the mandibular incisors. And the goal of this splint is that it helps to disocclude the posterior teeth. And this type of splint is also called the nociceptive trigeminal inhibition splint, because it has to decrease the activity of the trigeminal nerve. And the trigeminal nerve, when there is trigeminal nerve exacerbation, then often the patient has the habit of the parafunctional activity. So this type of the splint, when given, it helps to reduce the activity of the trigeminal nerve, and also helps to reduce the pain. So when there is occlusal interference in the posterior region, there is also the parafunctional activity of the muscle. So in such condition, when the permissive splint, that is the anterior deprogramming splint, is given, the posterior bite will be raised, and it will help to will prevent the interferences in the posterior region, and help to improve the function of the joint. Also, the splint can be divided into the full coverage splint or the partial coverage splint. And the full coverage splint, this generally covers all the teeth in the arch. And so when the full coverage splint is used, it generally helps to reduce the probability of the teeth moving when the patient uses the full coverage splint. Whereas in the partial coverage splint, the teeth that is not in contact of the splint, that will over-erupt, whereas the teeth that is in contact with the splint, that will intrude. So the partial coverage splint has some side effects. So this is the partial coverage splint, and this splint has only contact in the anterior region. So when the anterior region of the teeth contact, it will the teeth will generally intrude, whereas the other teeth which are not in contact, that will generally super erupt in this type of the partial coverage splint. Also, the splint can be divided into the maxillary, the mandibular splint, and the mandibular appliances splint generally is used because it causes less speech interference and also less visible when speaking, and so the mandibular appliances are generally used during the day. So it would be preferable to fabricate a mandibular appliance for a patient who is to wear an appliance during the day. So this is the mandibular occlusal splint. And the maxillary appliance is generally used when there is the periodontal, when there is periodontal disease, and also when there is the attrition of the teeth, then the maxillary occlusal splint is generally used. And also when there is the chances of the flaring of the maxillary teeth, then we can go for the maxillary occlusal splint. And also when there is decreased bone support or the compromised bone support, then we can go for the maxillary splint. And also when there is the more number of the missing teeth in the maxillary arch, then we can go for the maxillary occlusal splint. So in this fashion, there is attrition of the there is severe attrition of the teeth. So in such cases, generally the maxillary occlusal appliance is preferred than the mandibular occlusal appliance. So when there is more number of missing teeth, then the maxillary occlusal splint is fabricated, because in such cases the arch where there is more number of missing teeth will provide the greater occlusal stability. So this is the maxillary occlusal splint that is fabricated because it has more number of missing teeth in the maxilla. And also the splint can be divided into hard, intermediate, or the soft material. And the appliance material, whether it is a hard, intermediate, or soft material, there is no significant difference in the temporomandibular disorder symptom improvement. And so there is certain advantages of the occlusal splint that is fabricated with the hard or the intermediate material. And when the hard or the intermediate material is fabricated, it will provide a precise occlusal mark to provide the accurate adjustment of the appliances. And also when the relining of the occlusal splint is sometimes needed, then we can easily do in case of the hard or the intermediate material, but not in the when the material is soft. So when the material is soft, we cannot do the relining of the occlusal splint. And also when there is large discrepancies, we can easily repair in case of the repair when the appliance is made from the hard or the intermediate material. And also we can use the safe curing acrylic when there is missing contact in case of the hard or the intermediate material. So this is the figure showing the wearing of the occlusal appliances when the soft or the hard material is used. So when the hard acrylic material is used, there is less wearing away of the occlusal appliances. Whereas when the soft acrylic material, material is used for the fabrication of the occlusal appliance, it will generally have more wearing of the appliance. So this bypassed impact and the clear splint, these are the soft occlusal splint, and it will have more wearing of the appliances, whereas the Evo Cap, Eclipse, and the Pro Base, which are the hard material, this will have less wearing of the appliances. So the intermediate appliances will have certain advantages. That is, it will be more comfortable for the supporting teeth. And this software material, this will generally compensate when there is minor error, but not in the case of the hard acrylic material. So when there is minor error, this can be easily adapted in case of the soft material, but not in the hard acrylic material. And also when the material is soft, it can dissipate the occlusal forces. So the appliances made from either farm at room. So there is another material, that is the hybrid material. So the hybrid materials generally are firm at room temperature, but this hybrid material becomes very flexible when they are warmed. So some of the hybrid materials include these vinyl appliances, which are generally bioplast and the flexite, and also the strain and impact materials. These are the most commonly used hybrid materials. So the soft material, this will generally provide the these are generally fabricated from the soft thermoplastic sheet, that is generally wound and formed over the cast, and the thickness of the soft material is generally 0.15 inch, that is 3.8 mm thickness, which generally is used during the fabrication of the soft splint. And this occlusal splint, this should not be the thickness of this occlusal splint should not be greater than the patient's freeway space. And if the thickness of the occlusal splint is greater than the patient's freeway space, then it can also and it can result into the increase of the temporomandibular symptoms. So sometimes there is wearing of the occlusal splint, and in such cases we can do the repair of the occlusal splint can be done by the internal relining. When there is not proper fit of the occlusal splint, then we can do the repair of the occlusal appliance can be done both intraorally or the extraorally. But in the book by Kandasamy and Green, they suggested the suggested the repair of the appliance intraorally only. So in such cases, what we can do for the internal relining is that we can put the soft acrylic material over the internal surface of the splint, and we can then put the splint into the mouth and allow for the material to set. And once the material is set, we can remove the occlusal splint, and the excess material can be trimmed in the extraorally. So for the adjustment of the appliance, once the appliance fits comfortably and has the appropriate retention, we can the occlusal surface of the splint can be adjusted. So for the adjustment into the occlusal portion, the author has suggested that we should use the flat portion of the acrylic trimming bar for the trimming, because when we use the round portion of the trimming bar, then the lateral excursive interferences will not be removed. So the author has suggested that we should use the flat portion of the acrylic trimming bar in order to reduce the lateral excursive interferences. For the occlusal splint, while fabrication of the occlusal splint, only the supporting cusp, that is the for the occluding, only the parietal cusp of the maxillary arch and only the buccal cusp of the mandibular arch touches the appliance in the occlusal splint. So in order to for the trimming of the occlusal splint, this icofilm can be used in the anterior posterior direction, and the bite mark can be taken to this icofilm, that is the articulating paper, and we should not be using this articulating paper in this horizontal medial to lateral direction, because in such condition generally the patient has the chances of protecting the mandible when we use the icofilm, that is the articulating paper in the medial lateral direction. So we should use this articulating paper from the posterior to the anterior region rather than this from one side to the another side. And this the marking can be done through the use of the black icofilm in for the centrifugation contact, and for the excursive movement we can use the red articulating paper can be used for the marking of the excursive movements. And for the perforations, generally the perforations are about the cuspal region. So when the perforations occur in the generally occur in the cuspal region of the opposing tooth, and thus since these perforations generally occur in the cuspal region, this does not have any detrimental effect on the appliance efficiency. So for the repair of the occlusal appliance, what we can do is we can place the acrylic above the occlusal surface of the tooth, and we can place the occlusal splint above the in the mouth region, and ask the patient to bite, and once the appliance is set, we can remove the appliance from the mouth, and then we can accordingly trim the appliance. So this is the occlusal splint that is put into the mouth of the patient for the repair of the occlusal splint. And also we can do the repair of the broken appliances in the mouth itself. So for example, this is the broken occlusal splint, and it can be repaired in the mouth itself. For example, it has been placed in the mouth itself, and in the broken area we can add the intraoral occlusal. Intraorally, we can add the acrylic over the broken area, and once it is hardened, we can remove the appliance, and we can then do the trimming extraorally. So if there does not appear to be when the appliance is broken, and when we cannot find the why the appliance is broken, so then we must consider that the patient has the heavy parafunctional activity that may be leading to the fracture of the occlusal splint, and in such cases the occlusal appliance must be thickened. For the temporomandibular disorder, for the primary therapies in the when the temporomandibular disorder is during the day, so in such cases we should ask the patient to improve the sleep posture. That is when the patient is sleeping in the stomach, so we should be asking the patient to stop in the stomach, and we should also provide the stabilization appliance for the patient to wear at night, and we should also prescribe the medications like amitriptyline, which is amitriptyline, which is the sorry, I forgot which group it falls into. And we can also prescribe the cyclobenzaprine, which falls under anticonvulsant group of medicine. And we can also fabricate a soft appliance to oppose the patient's hard or the intermediate appliance. And we can also ask the patient to perform the relaxation session just prior to sleep. So for the patient with generally have the daytime temporomandibular disorder, so we can ask in such cases we can generally ask the patient to break the parafunctional habit or the muscle tensing habit during the day, and we can ask the patient to keep the masticatory muscles relaxed during the day, and we can also refer the patient to the psychologist to train the patient, and we can also refer the patient to the psychologist for the stress management and coping skills. We can provide the stabilization appliance to wear during the day, and we can also prescribe the tricyclic antidepressant, that is amitriptyline, and which does not cause the since it is used during the day, so we should not prescribe the drug which causes drowsiness. That is, in such cases we can give the desipramine tablet in the morning and in the afternoon. And in the patient who has both the TMJ symptoms both during the day and night, so in such cases we can give the medication like topical or the oral NSAIDs, muscle relaxants, or the tricyclic antidepressants. We can give the patient, ask the patient to perform the physiotherapy at home or receive them from the physical therapist. And we can give prescribe heat, ice, or the ultrasound or the eye interferosis. We can ask the patient to perform the jaw exercises. We can ask the patient to perform the head and neck posture improvement exercises, and we can also refer the patient for the cervical therapies that is provided by the physical therapist or to relieve the neck pain. So in some of the cases where there is failure to relieve the symptoms of the temporomandibular disorder, so in such cases, if the patient does not obtain the improvement using the for the several weeks, so we should, in such cases, we should consider the non-temporomandibular disorder such as neck pain, fibromyalgia, or the sleep apnea causing the pain in the TMJ. And since the management of the temporomandibular disorder generally includes the combination of therapies, and the various combination of therapies can help us to relieve the temporomandibular disorder. And this basically includes the various approaches, that is the stabilization appliance we can apply for the heat or cold, jaw exercises, posture training, yoga, physical therapy, acupuncture, relaxation, or the stress management. These various approaches can help in the management of the temporomandibular disorder. And in some of the cases of the temporomandibular disorder, it is better to delay the orthodontic treatment when the patient is using the occlusal appliance, and we cannot tolerate without the occlusal appliance. So in such cases, we can delay the orthodontic treatment. And if the temporomandibular disorder symptoms is very severe, so in such cases also we should wait for the temporomandibular disorder to be reduced before doing the orthodontic treatment. And also when there is this displacement with reduction with intermittent rocking, and if the rocking is more than once a week, in such cases also we can delay the orthodontic treatment, because it can sometimes lead to the continuous rocking of the joint. Since the patient has periodically some degree of the temporomandibular disorder exacerbation, so it is we should generally recommend the patient to continue the wearing of the occlusal appliance at night time, even though sometimes there is no longer needed of the occlusal appliance. We can advise the patient to wear during the night time. So there are some of the review articles, and I think we should, the time for this is limited. I think we should continue in the next. I'll share another link, then we can continue.